So I want to welcome everyone. My name is Dr. Elena Rios. I'm President and CEO of the National Hispanic Medical Association. We're here today in Washington, D.C. with a virtual congressional briefing. A congressional briefing, for those of you that don't know, is a time to educate congressional staffers from the Senate and Congress on policy recommendations from our members and our collaborators today. I just wanted to welcome our topic is the HHS response. HHS is the U.S. Department of Health and Human Services response to COVID-19 efforts for Latinos, especially with heart and lung disease. Just wanted to say a couple things. And that is that we all know that the Latino population has a lot of major issues we call social determinants of health. And we have decreased health care. We need more Medicaid, for example, more insurance. But we also have a lot of problems because Latinos work in small businesses in places where they are essential workers. And I just want to say on the positive note that Congress and the Senate is working on a bipartisan effort for a relief package that we hope will focus on the individuals and the families in our communities and in small businesses. But especially we're going to need more help with food, with the food banks and the school lunches and the SNAP programs, the unemployment, the housing issues, and especially jobs, now that we have this new testing and new enrollment into clinical trials for hopefully a vaccine soon. And I think that the leadership that we have in this congressional briefing is very important to hear what are the priorities of our leaders in the Senate and the Congress. And our first speaker is Senator Bob Menendez from New Jersey, a champion, and I have to say that we've just supported some of the bills that he has introduced. Senator Menendez.
Well, thank you, Dr. Rios, for your invitation to join you all today. I appreciate it, and I want to thank the National Hispanic Medical Association for all the work that you do in advancing the role of Latinos in healthcare and in addressing the racial and socioeconomic disparities, particularly that COVID-19 has laid bare. I have long believed that improving diversity in healthcare would go a long way to improving the health status of minority communities. Growing up in Union City, New Jersey, I could never have imagined that the son of Cuban refugees would one day represent New Jersey in the United States Senate. And I'm proud that New Jersey is the only state to send two racial minorities to the United States Senate. And it's my fervent hope that seeing me and my friend, Senator Cory Booker, shows young people growing up like I did that there is no limit as to how far you can go from your neighborhood while still helping your family and friends in their community. And I think that seeing all of you as physicians surely inspires young people in the communities that you serve. So I respect what you're doing, and I applaud what you're doing. As we face the COVID virus, it has upended life as we knew it. Even as millions of Americans shifted to sheltering at home and adjusted to restricted movements, Latinos disproportionately still went to work in high contact environments that left them at greater risk for COVID-19. According to the Center for Disease Control, roughly 26% of all individuals who died from COVID are Latino. And this is largely due to the disproportionate lack of health insurance coverage, being part of the essential workforce, and other social economic factors. And we know from work in these communities that many Latinos don't even trust the government, nor has the government done anything to earn their trust due to its gross mismanagement and failure to deliver a national response to the national challenge we have of this pandemic. It's the perfect storm for a virus like this to thrive. Throughout this pandemic, I've advocated for specific resources and support for minority communities. I recently introduced the COVID-19 Health Disparities Action Act that ensures that all communities have the resources they need to deal with the pandemic. My bill recognizes that communities of color have been disproportionately impacted by COVID-19 and would require targeted testing, contact tracing, public awareness outreach specifically geared towards these communities, and that these efforts be both culturally tailored and engage with the communities themselves. And I appreciate that the National Hispanic Medical Association is one of the endorsing organizations. And I want to thank you, Dr. Rios and NHMA, for that support. We have to commit to meeting people in their communities, ensuring that materials and outreach are available in their language and that there is access to culturally competent care. This means we have to recognize that different approaches are needed to how to address people where they live. For instance, in New Jersey, the state has recognized that drive-through mobile testing centers don't work in every community. So as it ramps up testing, it's improving testing access for non-drivers, which benefits communities of color. I've also been pushing the administration to improve communication in other languages. The pandemic does not recognize borders and boundaries, and until we do the work of reaching all of our communities with the right information, access to testing, access to a potential vaccine, access to necessary medical care, we won't be able to return into any semblance of normal. That's why I've been calling for better data collection, broad access to free testing, guarantees for access to vaccines once we have one, and improved policies to address systemic racism and bias in our healthcare system. And I hope you'll all work with me and your respective senators to ensure that we improve the health and well-being of our friends and our families. Thank you again for having me with you, and I look forward to working together to improve the pandemic response in every community because we're literally in this all together. Muchísimas gracias.
Thank you, Senator Menendez. Thank you, Senator Menendez. We're very happy to have you. And I just want to say that the National Hispanic Medical Association has endorsed your bill on the Health Disparities Action Act for against the pandemic. And at this point, we're going to have a welcome from Congressman Mario Diaz-Balart. Dan, is it working?
I would like to thank the National Hispanic Medical Association for inviting me to participate in this event. You're all about to hear from experts in the medical field who will be able to go into great detail on how COVID-19 has impacted our country and the Latino community within our country. So as a member of Congress, I would like to take a moment to discuss what the federal government has done thus far to aid our nation's healthcare infrastructure. So through multiple spending bills, Congress has allocated over $175 billion to assist hospitals and healthcare providers who are at the front lines of this fight of this virus. We have appropriated over $25 billion for research, development, manufacturing, purchasing, and administering of COVID-19 tests. To procure personal protective equipment, ventilators, and other medical supplies, we have allocated $16 billion for the Strategic National Stockpile. These figures are just a small sample of the work that Congress has done during this difficult and unprecedented time. I would also like to share with you my personal experience with the virus, just to highlight its seriousness. Go back to March 12th, 2020. After a session week here in Capitol Hill, I was advised by our family physician and friend, Dr. Mario Almeida, who's a medical genius. He said to self-quarantine in Washington just as a precaution, despite not knowing anybody that had been exposed to COVID-19 at that time. See, my wife's pre-existing conditions put her at exceptionally high risk, and we did not want to just risk jeopardizing her health or that of my sons. 5 days later, I became the first member of Congress to test positive for COVID-19. Now here's the strange part. I have no idea how or when I was exposed to the virus, despite being extremely careful, continually washing my hands and sanitizing my hands. What I do know is that the weeks that followed, I felt horribly bad, shivering with fever, coughing, and other symptoms of this virus. Thankfully, I never experienced shortness of breath or difficulty breathing or issues with my heart, but as we know, so many others have not been as lucky as I was. For over 3 weeks, I remained quarantined alone in Washington, D.C., while my family remained in Miami. Now, fortunately, I was one of the growing number of lucky people who fully and totally recovered from this horrific, horrific virus. In closing, I want to emphasize that while government can and has done much to combat this disease, we each have a personal responsibility to protect those around us from the virus. Social distancing, wearing a face mask, and staying home if you are sick or were exposed to the virus are all crucial actions that are recommended by the Centers of Disease Control and Prevention, the CDC. It can make the difference between life and death for someone with immunodeficiencies or pre-existing health conditions. Thank you once again for inviting me to join you today. May you have a wonderful time, and hopefully our country soon will recover from this horrific virus. Thank you so very much.
Thank you, Congressman Diaz-Balart. And again, thank you, Senator Menendez. We are now going to have, let me just show a couple of slides. A welcome to our sponsors today, the Aetna Foundation, Amgen, and the Pfizer Foundation. Next slide. We have very many cases and deaths happening right now. We have spikes happening, especially in, and I just put up 3 states because they have so many Hispanic populations. We call these areas within these states hotspots because these are places where we really need targeted resources, more leadership, more healthcare services, more physicians, and we all know more people to abide by our public health rules that we're going to hear about right now from the Surgeon General. Next slide. We also have with us today opportunities to announce because we are focused on the importance of lung disease and heart disease. Our first campaign that we are starting is a Stop Vaping campaign, the purpose of which is to develop health communications for Hispanic physicians and health professional spokespersons that will be used in videos to increase awareness about the severity of vaping and reducing the use among Hispanic middle school and high school students. I want to thank all the staff and our consultants who have developed great fact sheets and videos. You can get more information at our website at the nhmafoundation.org, and our sponsor is the Aetna Foundation, an affiliate of CVS Health. Next slide. One more thing I need to say is for our heart disease campaign, we have a special cardiovascular disease education, especially for Latinos with high cholesterol and who are post-MI. We are also looking for physician spokespersons for this campaign. One important thing, besides the congressional briefing today that is being supported, we have 4 state legislator briefings that we will be having in California, Florida, New York, and Texas. So if any of you out there interested in joining us, we have special slots for some of our doctors and health professionals to provide policy recommendations in those states. And our partner for that has been Amgen. Next slide. So now it gives me a great honor to welcome the Vice Admiral Jerome Adams, the Surgeon General of the United States.
Well, thank you very much. Buenos dias. Muchas gracias, Dr. Rios. Let me start by thanking NHMA for working to empower Hispanic physicians to be leaders who will help eliminate health disparities. And to all the physicians and clinicians listening, thank you so much for your service, for your sacrifices, particularly at a difficult time. This pandemic has hit us hard, particularly people of color and those who are older. And as you well know, and we've heard the members of Congress articulate, as well as Dr. Rios, the reasons are many, but they're rooted in both pre-existing medical and social conditions that conspire to reduce our resilience, our opportunity, and our health. I want to say that again because as a medical crowd, I want you to hear this. I want you to start repeating this. There are pre-existing medical conditions, but there are also pre-existing social conditions that we need to be paying attention to. It's important to remember that healthcare is critical. I'm proud to be a doctor. I still practice about a day a month at Walter Reed Medical Center, but as critical as healthcare is, health actually begins at home in communities that are designed to provide income and financial security, education, access to transportation, safe places to be active, healthy, affordable food, housing, and all these things, especially now we're seeing must be free of structural and institutional barriers related to race and bias. What we've observed in COVID-19 is a peeling back of the veneer of equal opportunity communities when it comes to these social determinants of health. For example, social distancing and teleworking are critical. I helped write the guidelines and say this is what you should be doing to stay safe from COVID-19. Yet, only 1 in 5 African Americans and 1 in 6 Hispanic Americans have a job that allows them to telework from home. We know people of color are more likely to live in densely packed urban areas and in multi-generational homes. They're also more likely to use public transportation. And combined, again, these pre-existing social conditions and factors create a greater risk for spread of a highly contagious disease like COVID-19. These social determinants also contribute to medical determinants. Chronic diseases such as diabetes, cardiovascular disease, hypertension, lung disease, that make individuals more susceptible to severe complications and death from COVID-19. And I am proud to show you that I carry my inhaler with me. I wish I didn't have to, but I'm proud to carry it because I want to represent the people out there who have these pre-existing medical conditions and let them understand that it should not be a determinant of whether or not you get to be Surgeon General of the United States, whether or not you were able to survive a pandemic, whether or not you are able to be your most complete and full self. American Indians and Alaska Natives, unfortunately, along with African Americans, are hospitalized at 5 times higher rates than whites. Hospitalization rates are 4.5 times higher for Hispanics compared to whites, and that's nationally. We know in some communities those disparities are even greater. So in short, this pandemic, this virus is exploiting and exacerbating pre-existing health disparities. We know that case rates are high and rising in many places across the country, particularly in communities with higher percentages of Latinos. Florida, Texas, Arizona, California account for over 50% of the new cases. We know that all of those areas also have higher percentages than the rest of the nation of Latinos and Hispanics. We've deployed teams to assist in surge testing and to identify and execute strategies to combat the spread in those areas specifically, in addition to all across the country. And the good news, and there is good news, is that we're making progress in the structures, processes, and knowledges needed to fight the pandemic. The U.S. has conducted over 50 million tests with approximately 9% of these tests returning positive. That number has been rising. We're worried about it, but it's still below that 10% threshold as a nation where we would be concerned in a major way about the entire country. We're now averaging about 800,000 tests per day. This happened in part to our opening of more than 500 community-based testing sites with the support of private sector partners and the United States Public Health Service Commission Corps, which I helped lead with Admiral Giroir. So I want you to know these testing sites are specifically placed in communities of color. 70% are located in socially vulnerable areas as categorized by housing, race, ethnicity, income, and language barriers. We also fund testing at 94% of America's community health centers, which predominantly serve communities of color. NHHS recently allocated $15 billion to Medicaid providers and $10 billion to safety net hospitals, which are sources of care for our most vulnerable. This is something I've been particularly concerned about pre-COVID, and that I'm glad to see that we're making progress on in the midst of COVID. HHS is supporting language assistance for those with limited English proficiency. For example, COVID-19 materials are available now in Spanish at coronavirus.gov. And the Office of Civil Rights recently issued a bulletin on ensuring the rights of persons with limited English proficiency in healthcare settings. Beyond testing work, CDC now requires all testing data reported by states to include information on race, ethnicity, and zip code to allow us to better understand how to protect our most vulnerable communities. And the Office of Minority Health recently funded Morehouse University with a $40 million cooperative agreement that supports information dissemination and linkages to care for racial and ethnic minority populations. These investments improvements are critical, but we're not stopping here. We have a better understanding of how to treat those who've been infected by the virus. And that means when people are diagnosed, fewer of them are dying, and they're staying in the hospital for less time than what they were before. Remdesivir and steroids, tailored approaches to ventilation have improved recovery rates, and more Americans are safely returning to their families. We're also developing a vaccine at a record pace as part of Operation Warp Speed. However, we know that having a vaccine available is only the first step. Ensuring all Americans have an equitable opportunity to receive the vaccine and combating vaccine hesitancy will be key towards achieving degrees of herd immunity and ensuring the protections of Americans against COVID-19. So I need your help. I need you to help make sure people understand that vaccines are safe and effective, and that we address people's concerns about taking vaccines. Please continue your conversations with patients, families, and colleagues about why all vaccines are important, whether from measles, flu, or COVID-19. Because I'm very concerned that we could have a safe and effective vaccine that actually worsens disparities if people of color aren't willing to accept it. And while I'm really excited about our record pace for development of a vaccine, Tony Fauci and I talk regularly, and he still thinks we could have a vaccine by December or even as early as November. I want you to remember, we do not need to wait for a vaccine to get back to normal. Italy, Spain, some of the hardest hit places in the world actually are reopening. They're going back to school. They're having soccer matches. They're open for tourism again. Why? Because they did the 3 W's. Wash your hands, wear a face mask, and watch your distance. The most immediate defense against this infection aren't fancy therapeutics. They aren't vaccines. They're those tried and true public health practices that I continue to preach about. Again, wash your hands frequently and thoroughly. Watch your distance, making sure you're staying at least 6 feet from others and avoiding crowded spaces, and wear a mask to protect others. We need to make sure people understand that the high degree of asymptomatic spread is why we encourage them to wear face coverings and masks. You can't look at someone and tell that they're sick. So, por favor, usa una mascara. And then finally, encourage people to stay at home when they are sick. I want you to know that you'll later discuss COVID's impact on those with lung disease more, but I want to applaud the National Hispanic Medical Association for supporting those with lung disease. As you all know, tobacco product use has been long a concern of the Office of the Surgeon General. Most people know me because I'm the guy on the side of the cigarette box. But I also recently released a Surgeon General's report on tobacco cessation that I hope you check out at surgeongeneral.gov. And hopefully you're aware of the fact that I put out Surgeon General's advisories during my tenure on marijuana usage in young people, which we know can impact the lungs because a primary way that people consume marijuana is by smoking it, and also for vaping in young people. Again, go to surgeongeneral.gov for more resources. For the healthcare professionals participating in today's briefing, set up systems now to ensure your patients and families get their flu shot this year. We know that we're going to have a flu season. We don't want it to be a bad one and have that double whammy of COVID and flu. The systems you put in place now will serve millions further on down the road. I also want to just finish by saying we have a pandemic of virus, but we also have a pandemic of misinformation. So please direct people to coronavirus.gov. The guidance there is available in both English and Spanish. And implementing this guidance in offices and homes and schools and communities will protect not just individuals, but everyone we love and know and care about. And I want to just mention really quickly that I've been working in this space long before COVID. We have 2 calls to action coming out that I want you to be aware of. The first is on maternal health. 700 women die in childbirth each year. Over 60% of these deaths are preventable. And women of color suffer disproportionate numbers of complications and a much higher risk of dying. I am worried. I'm worried because we know women have been avoiding prenatal care because of fear of COVID. And we know prenatal care is one of the #1 predictors of whether or not a mother and a baby will make it through the first year after delivery. So important that we get that message out now, that we amplify my call to action on maternal health when it comes out. I'll also be putting out a call to action on hypertension control for all Americans. Hypertension leads to largely preventable and rising rates of heart attacks, strokes, kidney disease, and heart failure. We also know it puts people at higher risk for COVID-19. In the most recent data, 1 of 2 Hispanic men and more than 1 in 3 Hispanic women has high blood pressure, and the rate of safe control is alarmingly low. 12.4% in men, 26.5% in women. That's why I'm making hypertension control a national priority and ask that you join me. So please help me amplify these 2 calls to action. These are unprecedented times. We've all been deeply affected by the pandemic, but despite these challenges, I remain steadfast in my resolve to use our scars, our losses, and lessons learned during COVID-19 as an opportunity, or perhaps once in a lifetime opportunity, while people are paying attention to the things that they wouldn't have been paying attention to were it not for COVID. Social determinants of health, the impacts of race and racism, pre-existing medical and social conditions. If we can use this opportunity to shine a light on these issues and to change systems and structures, we can make our communities healthier, more resilient, and more just. I want us to look back on this time and certainly be very understanding of and appropriately mournful for the lives that have been lost. But I also hope we'll look back on this time 5 to 10 years from now and say that was the time when we really finally got serious about recognizing and addressing health disparities and change things for the better for everyone. So thank you for the opportunity, Dr. Rios. Know how much I value my cooperation with, my partnership with the National Hispanic Medical Association and the work that you all do each and every day to support your clinicians and also to support the patients that you serve.
Thank you, Surgeon General Adams. I guess, Ben, are you controlling this? Can you hear me?
Yes.
Okay. Anyway, I just wanted to say thank you again, Surgeon General Adams. I do have one question very, very fast from a board member from the Rio Grande Valley, Dr. Francisco Fernandez. He's actually the founding dean of the medical school there called the University of Texas Rio Grande Valley. And he's in between clinics right now. So he asked me to read this to you. So Dr. Adams, thank you for your work, your service, and for your participation in the hearing today. He's zooming in, well, he was zooming in from Brownsville. There are reports of assistance from the governor's office in Washington, D.C., and these are the assistants, the Army, the Navy, extra physicians are in the area. The Rio Grande Valley actually covers about 1 million people. But we see that the resources are mainly centralized in established healthcare systems. They haven't gotten to the community yet. They have a few community centers, few community hospitals. And he wants to know, what's your office and other federal offices prepared to do for communities of color outside of the major healthcare systems, and especially with the border and the complexity of undocumented?
Fantastic question. One that I remain concerned about, and I know the challenges of the Rio Grande region. I actually used to live and work in Laredo and understand that what happens on one side of the border impacts what happens on the other side of the border. Whether or not people feel comfortable accessing health and healthcare services and being contact traced really determines what happens with this virus. So again, what I want you to know is a $40 million grant to Morehouse University That is just one example. It's not nearly enough, but it's one example of the tangible investments we're making in community outreach. Again, I talked about community health centers. We know that they're trusted sources of health information and of health care for many people in communities where they feel safe going regardless of their documentation and status. We're making sure we're doing outreach in different formats and in different languages, and also through different outlets. I just did interviews with Univision and Telemundo. I've worked with Jose Andres to make sure, and other influencers to get the message out. And I want you to know that I also have been pushing to make sure we're working directly with cities. We have an initiative now where we're reaching out to 200 cities in 2 weeks to make sure at the city level, people are getting the resources they need. Because one of the challenges is the public health infrastructure is designed for us to work with the states and with the governors. But in many cases, the problem isn't on a state level. It's actually in a very local region or on a very local level. So I think it's a concern that you raised that is very valid. I want you to know that I understand and hear that concern. We're trying to improve outreach and improve direct communication with hospitals and cities and mayors and local health departments. And I will be the first to admit that we have a lot more work to do, but I look forward to working with the National Hispanic Medical Association to get that work done. The final thing I would say to all of your members is, particularly if you're at an academic center or a hospital, reach out, feel free to reach out to my office. Follow me at surgeon_general on Twitter. I'm tweeting out information directed to the Hispanic and Latino communities. I'm trying to do more in Spanish. Unfortunately, I took 9 years of French and only one semester of Spanish, so my Spanish is terrible, but I'm willing to give it a try because I want people to understand how important it is for us to have this outreach and engagement. And I will work with you to try to get the message and the resources to the people who most need it.
Oh, thanks a lot, Dr. Adams. We have one more question again from Rio Grande Valley, Dr. Minerva Romero. Minerva, are you on? She's muted. Oh, there you go.
Dr. Romero, please ask your question.
Just ask a quick question to the Surgeon General. He's got to leave.
Are you muted?
I think she's muted.
Hi, can you hear me okay?
Yes, I can hear you now. Wonderful. Nice to see you.
General, nice to see you. Thank you for joining us. I really appreciate the time and all of the initiatives that are coming out of your office. I want to just emphasize how dire the situation here in the Valley has been. You know, just 2 weeks ago, we were at about 13,000 cases and 200 deaths. In just that span of time, as of yesterday, we actually are over 25,000 cases and nearly 800 deaths. We bear 14% of the COVID death burden for the state of Texas, yet the population here in the Valley is only 4% of the Texas state population. There are a lot of very unique dynamics here, and being that we're a medically underserved community and we don't have the same resources, we don't have the same personnel and staffing, I just want to emphasize how dire the situation is, and we need more specifics. What are the specifics of the help that is coming to the Valley? Because we need it on multiple levels. Again, thank you so much for taking the time and the opportunity to ask this question.
Absolutely, and thank you so much. And again, that is a very fair question to ask. The most honest thing I can tell you is, again, I grew up rural, I grew up poor, I grew up with health issues. I can very much empathize with your plight. I also lived and worked in the Rio Grande region, and so I understand the challenges that you face. The structure of the public health system in the U.S. is such that we work with the states. And so we're working with your governor, and I've been out to Texas twice in just the past few weeks, helping your governor understand the impacts of what's going on in that region, at risk to myself. Again, I have pre-existing conditions myself, and I felt it was important enough for me to come out there and speak to your governor personally. We're also sending resources directly to hospitals. We're doing community outreach. We're sending resources to community health centers that are in your areas, and I can send you a list of the community health centers in those regions that we're working with, that we funded testing for. We're also standing up testing sites, surge testing sites in those regions, and making sure testing is available for people who need it the most. And it is never enough, and it will never be quick enough, but we will continue to make sure we are focusing resources on the places that need it the most. So I share with you what we've done, not to say mission accomplished, and not to say that you should accept it as enough, but so that you know that we are aware of it, we are doing things, and we want to continue to work with you to find out the places that most need that attention. The final point I would make is this virus runs a disease course of about 2 weeks. You all as physicians know that. That means what we do now, we'll see the results of in 2 weeks. If people aren't wearing masks, if they aren't washing their hands, if they aren't watching their distance, in 2 weeks, this will be even worse. If they do these things, we can turn around this epidemic very quickly. So it is important that we make sure we have testing, that we have PPE, that we have remdesivir, and that we have steroids available. But we don't want to try to treat our way out of this problem, because you're just going to keep chasing your tail. We want to make sure we're also leaning into prevention, and that's where I need your help. Every single one of you that has a social media channel or is on Twitter or on Instagram or Facebook, please go to my handle and please tweet out, retweet the 3 W's, because that's how we turn this around. There will never be enough testing. There will never be enough PPE. There will never be enough of the resources that we treat with if we continue to see spread in cases going up exponentially. But we can turn this around. They did it in Arizona. Arizona was peaking 2-3 weeks ago, and now they've hit a crest and they're coming back down. We're even seeing Florida do the same thing. We can turn this around quickly if we lean into those tried and true public health practices. And again, know that I hear you, and I'm willing to work with you continually to make sure we're getting the resources to those who need it the most.
Okay, well, Surgeon General, again, Dr. Adams, we really appreciate you being on the call, and we know we have a lot of work to do, and we're very much involved with the vaccine enrollment for the clinical trials. I was at your meeting this last week, and I think that we also are in conversations with Daniel Dawes at the Morehouse School of Medicine. We want to build that infrastructure, but I think one lesson that we've learned is that we're always ignored. We need to be more, so we appreciate being at the table, but we need our communities in Florida and California and Texas to get that extra support from the Office of Minority Health and OASH, and build up the policies and programs targeted to our communities too. But
well, Dr. Rios has my personal cell number. I shouldn't tell you all that, but she's got it. If you're feeling ignored, tell her to give me a call or a text. Jose Andres has my personal cell number. Daniel Dawes has my personal cell number. Call me up, let me know, because I've spent my career trying to make sure we can correct the health inequities that have existed and plagued my family and the people I love. I want to work with you.
Thank you. Thank you very much. We have to move on to our next speaker.
Thank you, Dr. Rios.
Okay. Our next speaker, now we have to hear the heart disease part of our congressional briefing with Dr. Gladys Velarde, who is from Florida. Dr. Velarde, can you please go on? Let me ask everyone, if you have questions after Dr. Velarde's conversation, please print it in the chat room at the bottom of your screen. Thank you.
Thank you, Dr. Rios, and all distinguished participants. It really is an honor to be here and be part of this briefing and to present to you the impact of COVID-19 on Latinos, making a case for the vulnerable heart. and briefly reviewed some of the implications. Much of what I'm going to say has been said already, but it is important and it begs repeating. You know, as we speak, we have passed 16 million cases worldwide, and more than 650 deaths have been confirmed. I think that yesterday we crossed 150,000 deaths in the United States. And as you have probably heard already from Senator Menendez and the Surgeon General, we make up a significant proportion of the cases nationwide, at about 32%, which is much higher of the share of the population, of our share of the population. Next slide, please. So as of July of 18, we had hospitalization rates for Hispanics, and this number was already mentioned, of approximately 4.6 times the rate of non-Hispanic white persons. Compared to the non-Hispanic whites, if you look at the age groups, those hospitalization rates are significantly higher among children and the young adults. And the way population data from the CDC has shown that over 26% of those US COVID deaths were among Latinos. And this number may change as we hear stories from Texas and the Rio Grande. We wouldn't be surprised that these numbers of deaths increase. Next slide, please. But we saw this story unfolding before our eyes from the earlier experience in the north, in the northern parts of our country and other states. You can see that the infection rate is disproportionately higher in Latinos compared to their shared percentage in the population in New Jersey, in states like Utah, Washington. And when we looked at the death rates, and this is the partial death rates, disaggregated data from New York City, that's when we started to get really worried that communities of color were disproportionately affected, not only by hospitalizations, but by increased mortality, as we see here in New York City, where they represent a little less than 30% of the population and a much higher percentage of the death in that community, and similarly in Pennsylvania. Next slide, please. And I want to emphasize the association by age of the hospitalization rates. Click, please. You will see that if you look at children and young and teens, we lead, our Hispanics lead, and second to actually not second, they're the leading group of hospitalization rates in this young group. Next click, please. But it persists. The younger Hispanic seems to be most vulnerable, with higher hospitalization rates compared to other groups, along with non-Hispanic Blacks and Native American Indians. It is that group that seems to be affected. Next slide, please. So we've talked a lot about, the worst health outcomes that we see in our communities. And on the surface, you would say, well, they have a higher, the realization of the worst outcomes is just the tip of the iceberg. The high prevalence of risk factors, obesity, diabetes, metabolic syndrome, and underneath that, there's a whole structure of inequities that the Surgeon General mentioned with social determinants of health that have been present for a long, long time. And that have been acutely exacerbated by the pandemic. Occupation, income inequality, housing, poor nutrition, and issues with psychosocial stress, anxiety, depression, discrimination and racism playing a significant part, language barriers, and the issue of mistrust. And mistrust is really important. And I wish I had, and I will follow up with Senator Menendez, and would like to know in our brief time that remains, the issue of mistrust is really an issue that has not been viewed in the Latino community as being so prevalent as in the African American community. And now with the current national discourse being so inflammatory, it has consequences. The rhetoric of hatred and racism and division has really exacerbated this and has had significant impact. Restrictions imposed on individuals through the passage of the CARES Act, putting families that have mixed compositions with some undocumented members in their families, affecting their access to services. And this is an issue that needs to be tackled. Next slide, please. So Hispanics are more exposed. We're frontline essential workers. We cannot afford to isolate. We have multiple generation households, and that's a good thing. And in many ways, but in a situation like a pandemic, is not such a good thing. So that makes us more exposed. Next slide, please. And then we talk about comorbidities. And when we see comorbidities, and this slide reflects the most common underlying conditions as of July 18 data that the CDC has compiled. And you would see that hypertension is in excess of 50%, obesity, close to 50%, metabolic disease and cardiovascular disease are the leading medical conditions that exist in COVID-19 hospitalized patients. Next slide. And when you look at what is the higher prevalence in our community, well, then you have obesity being highly prevalent in the Hispanic community. Close to 50% of adults age 20 and older are more likely to be obese. Diabetes, click please. Diabetes also in excess of 20%. Hypertension, our number is not as bad as other communities, but the number control, as the Surgeon General alluded to, the control percentage of Latinos, Hispanics in the nation is horrendously low. Next slide. When we look at metabolic syndrome, this is data unpublished of a study that we just conducted in 400 subjects, and it shows that here Hispanics in the blue bars have more elements of the metabolic syndrome and higher prevalence of metabolic syndrome than other groups, to the tune of 45, 47%, closely followed by the African American group and then Southeast Asians. Next slide. So it's no surprise that when we see the parallel story being written here, we know that cardiovascular disease risk factors associate more with severe COVID-19. And that translates into an increased mortality, not only in those with underlying conditions, but a morbidity and mortality for those that have uncontrolled risk factors. So the control of risk factors is tremendously important. The part that gets a little bit more significant and bears mentioning is that when COVID-19 is severe, cardiovascular complications are seen irrespective of risk factors. So it is not really known if the presence of comorbidities poses an independent risk or whether it is mediated by other factors like age. But in Latinos, as I mentioned to you before from the earlier slide, they being younger overall when they're hospitalized, then that is a point that bears remembering and deserves further scrutiny. Next slide. So talking very simply with this diagram about the infection of COVID, we have a virus that has these spiky proteins that will get access into the host cell. And I'm using my mouse to try to guide you, but I don't think you're seeing what I'm seeing, but because I don't have a pointer, so I apologize for that. This interaction of the virus with the host cell is mediated by the link, which is called ACE2, which is an angiotensin converting enzyme receptor, and that is ubiquitous in many cells of the human body. when the spike protein of the viruses lands and docks in ACE2, it has to, for that to happen, it has to be activated by a protein in the host cell. Next slide. Once it introduces itself, it docks, it lands, is activated, it causes the infection, and the virus uses the host machinery to replicate and produce more viruses. And those viruses, using their attachment to ACE2, which you can find in highly populated areas of the lung, especially the alveoli, will infect and damage lung tissue. But it also, since ACE2 is found in the heart, in the kidneys and other organs, it will affect any organ. So this interaction is what causes the initial injury per se of the virus or infection. The exact mechanism, next slide please. The exact mechanism of the cardiac involvement it remains under investigation. Is not really known. Is an area of intense study. There is direct myocardial involvement or heart muscle involvement that is mediated by this ACE2 protein receptor. And there's also manifestations that are due to the response of the infected individual, our own innate autoimmune response to the virus can cause what we call the cytokine storm, with an imbalance of the response, and then the association with the lack of oxygen causing cells of the heart muscle to die, for example. And in terms of affecting the heart, it could be in the acute phase. So two patterns are seen in the acute phase, or it may develop later as the illness severity progresses. So the cardiac involvement can happen at any time. And the longer the infection lasts, the more likely the cardiac complications will arise. Next slide, please. So we ran the whole gamut. The clinical presentation runs the full gamut. All spectrum of cardiovascular complications are seen. It can start with mimicking a heart attack, presenting as a usual obstruction of a coronary artery with occlusion with thrombus in the small arteries of the heart. It can have, and many mimickers have been found. A stress-induced cardiomyopathy has been seen, that causing arrhythmias, leading to pump failure, cardiogenic shock, and having other complications as thromboembolic complications, which are not uncommon and uncommonly seen. And so this whole gamut can affect. The longer the infection, the higher the likelihood that they will be present. And it is important to remember that with the use of cardiac biomarkers, we have detected that myocardial injury is present in the COVID-19 critical cases in greater than 25% of those cases. Next slide, please. So treatment. That's the treatment. Specific for the heart, there's no specific treatment for the heart. No treatment, unfortunately. Our treatment is supportive care. When a cardiac condition is seen, we treat the cardiac condition as we routinely treat it with antiarrhythmics. If there's an arrhythmia, if there's pump failure or heart failure, we treat the heart failure with the armamentarium that we have currently to treat any heart failure presentation. But in the background, we have the supportive care of the pulmonary support, because this is primarily a respiratory disease condition that affects other organs. So we give pulmonary support, we offer immunomodulation, and anticoagulation is getting more and more, becoming more prominent in our bag of tricks, if you will, since we don't have treatment for COVID-19 at present time. Next slide, please. So our challenges, these are challenging times. It has been said by the prior speakers that certainly for us in medicine and in the scientific community, I believe this is probably the most challenge, the challenge of our lifetime. And this infection has highlighted the existing health disparities that have affected Latinos and communities of color and those living in poverty. But on the positive side, it gives us an opportunity, if there's any silver lining, to really refocus and act on addressing health inequities that have been present there for so long and have been worsened by the pandemic. And I want to commend what the National Hispanic Medical Association has been doing to push, the envelope, to really allocate the resources to look at policy fixes that really go to the root of the problem. And I want to emphasize the need for data. The need for data. Data is critical. From the cellular level to the public health level is desperately needed in communities of color, especially in the Latino community, because we're a heterogeneous group that shares many factors, but some of them are more unique to other Hispanic groups and subgroups. Next slide. So I just leave you with this thought from von Gogh, a German writer. Knowing it is not enough. We must apply and we must do. Thank you. Thank you, Elena. Thank you, Dr. Rios.
Thank you, Dr. Velarde. It's important to know that lung disease and heart disease patients are the most affected by COVID-19, and that's why we had this congressional briefing focus. And thank you for your expertise. I just want to say a couple words. I want to thank everybody that made this possible, especially Ben Milano and the rest of our staff. I want to ask you to please go to our Twitter. We do have a hashtag of NHMA COVID-19 for lessons learned today and other lessons learned. I would just want to mention a couple policies that have come up on the chat in terms of the importance of Congress looking at the next bailout, the next relief for Latino communities, that we need to look at immigrants, detention centers, prisons, meals. More people are going to be unemployed. We know we're going to have food banks, and we are going to have more people unemployed. We do need that unemployment. We do need Medicaid expansion. We do need medications for obesity, which leads to heart disease. Should be under the, we had a special policy announcement that under this Public Health Emergency Act that we are living under right now, we should be able to have new medications for obesity, for weight management, and also the concept of health workers and the Healthcare Resiliency Act to have mental health of our health workers. And then lastly, one message from our Board of Directors Chairwoman, Dr. Nelly Correa. Nelly, are you on the phone? On the chat, on the video, I'm sorry, Nelly.
Hi, can you hear me?
Yes.
Well, so I just wanted to say, as chair of NHMA and thinking about all our Hispanic communities across this country, I want to thank Dr. Velarde, and I want to thank the Surgeon General, Dr. Adams, but also I want to make a call to action. A week ago, we realized what was going on in the Valley, and we know that almost 100% of the population of the Texas Valley, Brownsville, and that area is Hispanic. And we want to make sure that we, across the country, as Hispanic physicians, support these communities. As a doctor that worked in New York during the recent pandemic, we had a lot of assistance from across the US. And we also had the National Guard come and help us in the hospitals, set up field hospitals, and we had a ship that came and also offered care, even though not COVID care. We, as the physicians in the National Hispanic Medical Association, need to urge our congresspeople and our government, our federal government, not to abandon these communities. We were all dismayed to read that in the Texas Valley, they were having ethics committees set up, and that they were asking some people, making choices about who was admitted and who gets to go home.
Right.
We as
Well, Dr. Correa, I hate to stop you, but we are over time.
Okay.
I just want to say once again, that just to let you know that we are very much interested in the call to action, and how we do need to talk to our own congressmen. And this is what our congressional briefings are about. And let me say that this briefing will be recorded, has been recorded, and will be available at our website, www.nhmamd.org. And I want to thank Dr. Velarde for your excellent presentation on heart disease, and all of our speakers today. With that, we're going to leave you. Thank you very much. And thank you, Nelly,
Thank you.
Dr. Correa, Dr. Minerva Romero, and Dr. Francisco Fernandez from the Valley for making the statements today. Thank you very much.
Thank you.